Welcome back to the Faculty Factory podcast, friends. It's Kim Skorupski here at UTMB, the University of Texas Medical Branch in Galveston, Texas, where we have relationships with 147 countries on every continent around the world. Most recently in Egypt, where we're collaborating in a new school of medicine there in Egypt. And did you know, because I didn't, that Galveston is the third oldest Mardi Gras celebration location and arguably the largest motorcycle rally in the United States. It's a really awesome place. And I happen to be looking at our guest today who has something in common with Galveston, Texas. And I recently learned that. So I'm so excited to welcome to the podcast today, Dr. Nicole Piemonte.
Hi, Kim. Thank you so much for having me. And I am delighted to know that we have a connection through Galveston. I certainly remember the biker rally, definitely. And I absolutely remember the Mardi Gras celebrations.
Wonderful. Well, folks, let me tell you about Dr. Piemonte. Nicole has her own coaching practice. It's called Meaning in Medicine, LLC. So check out Meaning in Medicine. We'll have a link on the facultyfactory.org website. She is the Associate Dean for Faculty Leadership and Associate Clinical Professor for Medical Humanities, both at Creighton University's School of Medicine at the Phoenix, Arizona location. Also, the author of two books, Afflicted, How Vulnerability Can Heal Medical Education and Practice, and most recently, Death and Dying, where she talks about end-of-life conversations. So as I mentioned, she is a certified professional coach from the Healthcare Leadership Coaching Society, International Coaching Federation certified. She has some wonderful content, a great heart, rich and deep history in academic health. And so again, Dr. Nicole Piemonte, take it away.
Thank you, Kim, and thank you for that generous introduction. It's very kind. I'm grateful to be here, grateful to be talking to you, someone who is connected to a university that has meant a lot to me at UTMB. At the time that I attended what is now the Institute for Bioethics and Health Humanities was the Institute for Medical Humanities, where I got a PhD in medical humanities, the only place in the world that I could get a PhD in medical humanities. And it's really a transformative experience for me. Before I had attended, I had recently lost my mom after taking care of her. She had ovarian cancer. And she died right before I moved to Galveston to start my PhD. And my work at UTMB at the time was focused on vulnerability or the lack of vulnerability in medicine. And the question that kept swirling around my head was, how was it that my mom, who was a nurse and very likely knew she was dying, when in the hospital, she was offered like a fourth line chemotherapy treatment, and then died 6 hours later, and why we didn't have a conversation around death, and that there wasn't an honest conversation around that with her physicians. It had been surprising to me because she's offered this new line of chemotherapy. We think we're going to do that. And then a few hours later, a palliative medicine doctor's in there. I didn't even know what that was. And then she died, what to us seemed very suddenly. And what I learned is that we were not, and still struggle to, train our future clinicians to be present with vulnerability, to be present with death and dying, and to have these end of life conversations. And so this wasn't a moral failing of my mom's clinicians. This was the fact that it is much easier to teach a technician than it is to teach or train a healer who can be present with suffering, especially suffering that might be existential or spiritual or emotional. So I've kind of dedicated much of my work to thinking about ways to cultivate vulnerability safely for our clinicians so that they are prepared for the realities of healthcare. And while I've had opportunities to create curriculum around that, especially at Creighton, which has been amazing, now, and then, I served as this Dean of Student Affairs over at Creighton, and a lot of those themes kept bubbling up. Vulnerability, and are we really helping our students be prepared for that? And then now as a coach, I feel like I'm creating a space for clinicians to be able to grapple with um, vulnerability, with questions of their own self-efficacy, imposter phenomenon, and giving a space for that. And so my work seems much more applied these days.
Well, thank you for sharing your story, and sorry about the story about your mom, but it's exactly what you in your presence by sharing that story that makes you so real and makes us so real when we are in community with others,
Yes.
colleagues, learners, supervisors, professional societies, the public, our patients, when we can be honest about we all have tragedy, we all have stories, and that humanizes us because after all, and I know you do a lot in values-based leadership and your leadership work and the fact that you actually created and developed the master's program of medical humanities there at Creighton. I mean, you get this, you understand not only the intellectual content, but that human side. I think that is what is really so rich. And and everybody listening to this podcast knows that when you enter into or embed in a conversation, let me tell you a story.
Mhm.
Or let me share something. Is it okay if I share something about myself? The whole tone and temperature
Yes.
changes. Any classroom, any bedside, any hallway, any coffee lounge, professional society, when you just yammer blah, 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 medical terminology and facts and figures and numbers and tables and charts, yes, that's expected. And when you layer in that, let me tell you about my mom,
Yeah.
like the room gets silent. There's something that connects us at the heart. And so that's what I can't wait to get into this conversation. I promised that I was not going to be talking a lot. So I here I am zipping my lip. Dr. Piemonte, please continue.
Kim, thank you for highlighting that the importance of stories. So when I give talks at various places, um, I may or may not, but I may share the story of my mom, and then a few years later, actually losing my dad, and what that has been like, and how that helps enrich my understanding of medicine and medical education and healthcare. And inevitably, after I give a talk like that, I'm in conversation afterwards with people who feel that there is an opportunity for them to share maybe their own suffering and how that informs their work. That's the core of the health humanities. That story is transformative. So, how are we going to teach first and second year medical students, for instance, the lived experience of illness and the nature of suffering if they may not have had that experience with a family member or their own illness experience? Some of them have, but very few have. It's through story, it's through hearing from patients themselves, it's through film and documentary. It's through a novel or short story. It's never going to be through stats and figures and tables on a slide of the various ways that people suffer. It is through story. So I do think story is powerful. And that's why I want to carve out spaces in healthcare for people to be vulnerable enough to speak about their own lives. Um, and that's where I think real compassion comes from because people are able to tap into their own suffering in order to feel alongside their patients or others who are suffering.
Yeah. I'm putting my hat on as a faculty member where we're so trained to be unbiased, scientific, logical, rational, focused on productivity and generating revenue and generating scholarship and building collaborations, all that doing, 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 and looked upon as the expert and all of those kind of stereotypes we place about the faculty members and leaders in academic health.
Mhm.
How do we balance that as a faculty member with the fact that, yes, I am like an onion. There are many layers to me. I too am someone's daughter, someone's son, someone's partner, someone's mom, someone's dad. How do we bring those worlds together without being overly personal or too woo-woo, or making our deans, our leaders, our patients feel like this is kind of inappropriate. Is this person taking their science this seriously, or is this a physician or a clinician I can trust?
Yeah.
They're really a little bit, they're not like I thought. So how do we, in reality, what can we do that can bring the fullness of ourselves to these relationships without being so vulnerable that maybe someone's going to use it against me?
Mm,
Nicole, these, I'm sure you coach hundreds of faculty members. You see it, we know it's part of them, but
yeah.
they don't want to necessarily divulge it because there's some fear that, first of all, I won't be viewed as being serious, but also someone could take advantage of the fact that I just shared with you that, my gosh, I have some struggles at home, or I've got some family things I'm going through, and I don't feel like I can be present for the next couple of weeks or that meeting next month. I need someone. How do you coach them, or what words do you have about this whole topic?
Such a great question. And I don't want to misrepresent the idea of vulnerability, that it is, oversharing or overconnecting or being inappropriate in situations. And so there is some mindfulness that comes there. What I suppose is most important is, let's talk about compassion, for instance. If we go to the etymological root of it, like the Latin root of compassion, we've got passion, which is the experience of pain. This is why you hear things like the Passion of the Christ, right? Like it's the experience of pain. And then we have come, which is combination or in union together. So compassion literally means the experience of feeling pain together, the co-feeling. So connecting to my own pain doesn't necessarily mean I'm talking about it or telling stories about it, but it might be in order to have compassion for this student or this patient. I have to be willing to tap into my own experience of pain and suffering to feel alongside this person. It's not about pitying them. It's not about sympathy. It's kind of about empathy, but it's about co-feeling. And that's what compassion means. So we are always already our personal and professional self all of the time. What happens at home affects us at work. What happens at work affects us at home. To pretend that that is not the reality and to keep maintaining the what we call like a professional distance. I have to keep this person at arm's length. My first year medical students start talking about this the second week of school. Oh, I cannot connect with patients. I can't overly connect because then I'll burn out. That's what they believe. But really, it's the connecting with the patient, tapping into my own potential for suffering. That is what creates deep meaning, a sense of purpose. And when you look at the literature, when we maintain professional distance and don't connect, this is ironically what leads to burnout. This is what creates kind of like factory line engagement with patients. You see them every 15 minutes. It's just transactional to generate our views. That's what's burning people out. Not connecting with people and recognizing that we are vulnerable together on this earth. And we need to create opportunities for real connection for our students, for our residents, for our faculty, to understand that tapping into our vulnerability is not scary, it's human, and it is what allows us to connect to people. And it's not creating burnout. Oftentimes, Kim, people talk about compassion fatigue. You hear it all the time. And what we see is that it is not compassion or co-feeling that is fatiguing us, because there's neuroscience studies show that having compassion leads to compassionate action. And when I engage in that action, I feel energized, I feel connected, I feel my work is meaningful. But we are being fatigued by something. So what is it? What is it that clinicians are being fatigued by? What is it that people who work with students who might be suffering, what are they fatigued by? What's going on here? It's the fact that the cycle of compassion cannot be completed as healthcare stands right now. So you might see a suffering patient, feel compassion, and it might be that they're dying or it's a trauma and they die at the end of it and it's tragic and terrible and you can't make good on your compassion. And absolutely, that can be emotionally exhausting, fatiguing, damaging. What I am most worried about is the fact that so many of our clinicians see someone who's suffering, experience compassion that inspires action, but they can't make good on it because of insurance claims or values mismatch between their healthcare organization and what they feel called to do, lack of resources. You think of COVID when our clinicians didn't have the right resources to connect with people. That is what's fatiguing people, not being able to make good on their compassion because they're told they only have 15 minutes to talk to someone. It's not the connection that's causing it, it's the lack of connection that's causing it. And as faculty, I think we should be concerned about that.
Wow, Nicole, that is some real truth there. Real truth. That burnout, like you're saying, I'm taking it even like in the clinical office or clinical space, yes. Also back in the scholarship, the academic side of the house, where we're like, I'm not able to bring that to closure. I have ideas for scholarship and books and papers and presentations and other creative outlets. I don't have capacity to close that loop. So I have so much that I want to give, and those moments are fleeting, and I'm not completing that circle either. So I hear what you're saying, Nicole. It's like we don't have space to complete any circle because it sounds like it's structural. If the systems are built to
Yes.
frustrate those those loops.
Such a great point that you're making here. And what I hear when you say that is that what crosses the lines between whether it's clinical space or academic space, traditionally academic space, is the lack of opportunity to bring our whole selves to our work. So I might be passionate about research, but if it's not aligned with the productivity metrics that I have to get done in order to, I don't know, have promotion and tenure, whatever it might be, I can't explore the things that I'm passionate about because maybe the funding's not there or whatever it is. I can't teach what I'm passionate about, then I can't bring my whole self. And so we've been selling people this bill of goods that we can't make good on in higher ed and in the healthcare space because people have to shrink themselves to become what the organization needs.
I love that image, shrinking ourselves. It's to me, it's a almost gosh, it's this interesting way of thinking. Sometimes when I think of faculty in the space of academic health, I feel like they are pulled and stretched and so to me that's like big and stretched thin and wide. And the irony, the paradox, is that that being stretched actually shrinks.
Yes.
Oh, isn't that kind of mind blowing? You're exactly right, Nicole.
That is so well said. This idea of stretch our clinicians to see as many patients as possible, stretch our academic faculty to do as much as possible. In that stretching of doing, I think we're shrinking our being, who we are. Yeah.
Gosh, you're right. So what can we do? Because I think a lot of the times, we've had conversations with many people around the North America about burnout and resilience, and we've all had similar conversations of you can't just toss a yoga mat at a faculty person and say you're burned out because there's something wrong with you. You better fix yourself. You better get straight. Drink some more water. You better do some more mindfulness. And we inevitably come back to these are systems level issues that we have to
Yeah.
change the way we finance healthcare, the way
Yeah.
we bill, the way we um, dedicate resources, the way we budget time and humans. So, outside of our being any of us listening to this
Yes.
podcast have the ability to do that, what can we do? What are some examples of how you coach and through your work, you provide examples of opportunities to um, kind of fix that gap or close that gap of shrinking, stretching?
That's the major problem, isn't it? And we all know that the whole healthcare system needs an entire rethink. And that's putting it kindly of the state of our healthcare system. And until some of those much larger economic and sociological issues are addressed, this is kind of what we've got. Um, Working in medicine and healthcare has pushed me to become very practical in some of our approaches. What can we actually do? So the research shows that, let's talk about clinicians for a minute. Research shows that by and large, clinicians are more resilient than the lay population. You think of the training programs they had to get through in order to be here. So it's not about let's give them like remedial resiliency training. That's not what we're talking about. They are resilient. So what are we talking about? I think we're talking about getting them reconnected to themselves. How do we get them reconnected to themselves so they can bring their whole selves to clinical practice, for instance? So what does that look like? Coaching is one way, right? Therapy is another way. But in coaching, I try to get people who, by and large, have neglected thinking about themselves or their pain for a very long time because they've had to. We talk about delayed gratification and all of these things. So they've been kind of trained to not think about what's going on inside. And so coaching can be a space for them to start to reflect on, wow, am I actually doing what I really want to be doing? Is this what I'm passionate about? Am I connecting to people and helping them to reconnect to people? So, coaching is one of those things. Another thing is normalizing vulnerability and normalizing that for our clinicians and for our students, for our residents. One thing we do at our hospital, and many of your listeners will be familiar with this, is Schwartz rounds. This was, created in the 90s. Ken Schwartz was a healthcare attorney who died of lung cancer when he was 40, and he had decided that, he wrote a piece in the Boston Globe that his caregivers are what made the unbearable bearable. And he had fear that managed care organizations that were developing in that time, PPOs, were stripping the compassion out of medicine and making it transactional. So his dying wish was for a center that was dedicated to compassion. So we've got the Schwartz Center out in Massachusetts. I had the amazing opportunity to be at Mass Gen Hospital last week, where Schwartz Rounds was started, and to kind of meet the people who've been there from the start. And what Schwartz Rounds are getting everybody in the hospital who wants to attend together, staff from everywhere, and you've got a panel of 3 to 4 people, either talking about a difficult case or a theme. And they're talking about what it feels like to be a clinician or a hospital staff person taking care of patients and how painful that can be, or how beautiful that can be. And then their stories are very short, back to stories and how powerful they are. And the rest of the people who are in attendance share their experience and their stories. People who are familiar with Ballant groups, it's kind of like a giant Ballant group. And we are normalizing people sharing their stories. And this has become standing room only at our hospital. And I do think we are chipping away at letting people say you can be your whole self at work and you will be seen and known and connected to other people.
Well, amen. Yes, absolutely. So, what can we do? We can reconnect to ourselves and
Yes.
provide opportunities, even if you, again, feeling, well, I can't do this. I can't do this Schwartz runs at my place. You can do something in your
Yes.
clinic, your lab, your division, your department. You can start those conversations where, again, you're destigmatizing vulnerable situations in life.
Yes.
You're making it normal to talk about, oh my gosh, I'm struggling with this, or my marriage that, or my kids this, or my parents that,
Yep.
or my nagging pain this. And normal, like I'm a gerontologist, so I'm trying very hard to normalize the life course and aging and destigmatizing aging. This is just normal. We all are doing it. Let's not
Yeah.
pretend it's not going to happen. So I love those two recommendations of looking inward, taking a moment, and then providing opportunities for stories. But I'd like to go back to this, Nicole, the first one, um, re-examining who am I, what am I doing here, where are my values, and should we wait until the dashboard light is
Mm,
blinking before we stop? Because I know there are faculty members who will be who roll their eyes metaphorically and in real life, like, I don't need to be doing that. I know what my values are. Do they change over time? What
yeah.
happens, Nicole, when that I'm in a groove, I'm in a great groove, in a great groove, and guess what? Now I'm maybe 40, 50, and that groove is now kind of a rut.
Yeah.
So the question
Yeah.
to you is talk about the value, if you will, of not waiting till everything's blown up till you say, wait a minute, whoa, 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 am I doing, who am I? What happened? Where is this me? What do
Yes.
you notice in your
Yes.
career and your practice about the timeliness of starting with self first?
Yes. So I like that question of timeliness. And, I'm at Creighton, which is a Jesuit university, focus on liberal arts. They're very open to the humanities. And so we start day one with our medical students on self-reflection. Jesuits are very into reflection and self-reflection, which is so great, especially for a medical humanist like me, to walk in there and say, okay, we're going to get our students reflecting. So what does that look like? Before they have an ethics or humanities session, or even other areas of the curriculum, we have them write a really brief reflection. Write. We have medical students write a very brief reflection. And then we try to transform so much of their learning experiences into being small group dialogue, conversation, reflection. Okay. So when we're teaching them this kind of difficult stuff in the medical humanities about how can you understand the lived experience of your patients, it's about understanding who they are. And I don't know what it is we're doing at Creighton, but we get very few complaints about these reflections. Students want to reflect. We also have a medical humanities student group. They wanted to start their own little organization outside of the curriculum. And they asked me to be their faculty moderator. And every other month we get together and we reflect and talk. And they decide on the topic. So the last time we met, they wanted to talk about imposter phenomenon and why they feel like they are not made to be here and giving them a space to talk about that. Um, Earlier this week, I went to see the OBGYN residents, and they were reflecting on times when, God, a baby dies, and that they feel like they have no opportunity to debrief and feel their feelings. And we share about what that's like and what ways the systems need to change to acknowledge that they are whole people who feel, in some ways, traumatized by those experiences. And then finally, like, let's say lowercase v vulnerability. Easy low hanging fruit for vulnerability. Starting a faculty meeting off with the first 3 minutes is a reflection and saying, would someone like to share something that has stood out to you over the last couple of weeks? Whether that was a difficult patient experience or a great experience with a student, share what just stands out in your mind or share something difficult or something wonderful. And that is so easy. 3 minutes, and you switch off of the person at the next faculty meeting and they share something other than their quote unquote day to day work and start to acknowledge how they feel.
Because guess what? We're not machines. We're not
That's right.
robots. Actual human beings. That's profound to me. I've seen that because I come from, um, admittedly, being a high T on the Myers-Briggs, a thinking kind of like roll your sleeves up, get to work. I don't have time for emotions and feelings and relationships. We've got work to do. And that's the way I was used to going and living and being.
Yeah.
And so I always kind of poo-pooed the idea of people don't care what you know. They want to know that you care. And I always heard that and I'd be like, ugh, people don't care what I know. They want to know that I care, please. And
Yeah.
I'll tell you, I was really slow to learn the value of relationships
Yeah.
and slowing down. And unless you have a patient on the table, there's nothing more important than that I see you.
That's right.
I see you. Let's
Yes.
be there for a second. That's what's the stop
Yeah.
rushing around. Why? There's no need to be hustle and grind all the time. In our own minds, we feel that that is a, and so not only is it harmful, I think, for relationships, but then it also, and I'd love to get somebody on here to talk about this, it gets us into this habituation
Yeah.
of hustle, grind, hustle, grind, hustle, grind, almost like conflict habituation, that if you're not in conflict or you're not hustling
Yeah.
and you're not grinding, your body neurologically, you don't know how to shut down
Yeah.
and slow down. People go on vacation and they can't vacation. They can't lie on a couch or sit on a beach. They can't because we have trained ourselves to be go, 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 go. So I think,
Absolutely.
yeah.
Yes. We are there's almost an archetype that this is a broad generalization, but there's almost an archetype that is drawn to healthcare and medicine, and they very much have been programmed to achieve. Achievement is so seductive, especially if there is some kind of pain on the inside or doubts about who we are and how good we are. If we can achieve and get that external validation, that can become addictive, even in my own life, right? And what we need to create is opportunities for what we call post-traumatic growth. We're all familiar with post-traumatic stress, but what is post-traumatic growth? We know intuitively what that means, that through difficult experiences, if we process them and allow them to change us, we are different on the other side. And hopefully we've grown. And we have to slow down to experience post-traumatic growth, which is that opportunity to feel our pain. When my mom died and then I went and got a PhD, maybe it looked like I was experiencing post-traumatic growth because I was like, oh, look, I'm studying vulnerability and end-of-life conversations. That's what happened with my mom and me. I was not. I was running from myself. If I could just achieve and get that validation, then I would feel better. And it wasn't until a few years later, my dad died and I had to face it again, that I was like, wow, I need to process this. And I can say that I then experienced finally post-traumatic growth, a lot of work. And now I feel like I can connect to others better. I understand suffering a little bit more deeply, and I don't feel as much that need to run, 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 achieve, achieve, achieve. And the beautiful thing about healthcare and the hard thing is that there is so much suffering that there are moments for post-traumatic growth all over the place. If we allow people the opportunity to acknowledge them, talk about them, say how difficult it is, and grow from it. And I think we, as faculty and educators, are called to do that. We have to help facilitate this with our students.
So inspiring. I definitely want to have you back. Folks, please go to Meaning in Medicine, LLC. We'll have links on the facultyfactory.org website. Bye now. Hi, Faculty Factory friends. It's Kim Skorupski here. Just a quick commercial for our upcoming Faculty Leadership Collaborative Mid-Career Boot Camp. We're hot off the 3-day Faculty Leadership Collaborative Early Career Boot Camp, where we had about 72 assistant professors from around the country and the world. It was so awesome. Well, the 3-day mid-career boot camp for associate professors is April 9th to 11th, 2025, 2 to 5 p.m. Central Standard Time, all via Zoom. The topics for the mid-career bootcamp will include Leadership Presence and Self-Management by Joe Losey at Pitt, Communicating with Emotional Intelligence with Alice Fernari from Hofstra, Leading Organizational Change with Susan Chubinskaya right here at University of Texas Medical Branch. Conflict Management and Mediation with Dave Usum from Hopkins. Strategic Thinking, Planning, and Negotiating with Rejma Jagzi from Emory. Building and Managing Teams and Projects with Wendy Bennett from Hopkins and Darpan Patel from the University of Texas Medical Branch. Finances and Funds Flow with Vin Pellegrini from Dartmouth. And Creating a Leadership Future, Preparing for Transitions with Archana Chatterjee from Rosalind Franklin. We're also going to have a panel of recently promoted professors who will share their journeys. You'll get 9 contact hours of CME, CNE, and CLS continuing education credits. You've got a curated resource guide, lots of networking opportunities. We have a half hour before, half hour after each day's events for just more community building and networking and Q&A. So go to the facultyfactory.org website. That's facultyfactory.org website. You'll find the link right there on the first page to sign up and share it with your colleagues and friends. Thanks for tuning in to the Faculty Factory podcast. We are a faculty development community sharing tools to build academic leaders in healthcare. Maybe you want to be interviewed on the podcast? Please visit facultyfactory.org/contact and send me a message there. The Faculty Factory podcast and website is sponsored by the Office of Faculty Affairs at the University of Texas Medical Branch in Galveston, Texas.